sharing experiences, really important, learning from each other, hearing from our expert speakers.
I want everyone to really take control of their health, because it's your body and your life, and if you're not in control of it, no one else will be.
Turns out that almost all pacemakers are completely fine to go through an MRI scan.
Both septal ablation and surgical treatment show good results. It's safe, comparable.
HRT for many women is a lifesaver.
However, and it was a real shock, they told me I did need a transplant.
It's funny being a carer. You know, sometimes people don't take their medicines properly and you get cross at them. Why are you not taking your medicines?
I would say the next big stage in the development of this story was our understanding that this is, in many people, a genetic condition. So it's a heritable and transmissible disease.
So some of the pros of genetic testing are that we can find a causative gene change in some people.
Thank you. Okay, so yeah, my name's Gabby, and I'm a paediatric cardiologist that works at Great Ormond Street Hospital here in London. So thanks very much for having me to come talk to you today. So I'm going to just give a little bit of a overview of the types of cardiomyopathies that we see in children and when we see them and what the causes are, and then go on to looking at what's new in cardiomyopathies for young people and children at the moment. So some of these slides you might already have seen if you were in Professor Elliott's talk just now, but as he was saying that we have this new guideline that was published last year, which covers all cardiomyopathies, so all heart muscle disease. And what was new for this guideline from our point of view as looking after young people was that actually for the first time there was sort of recognition that actually, although we always recognise that they presented in children and adults, that actually the underlying causes and the way that we treat them actually is quite similar in children and adults. So actually there isn't this separation that we used to see between things being very different in children to adults is actually not there. So now we should be really delivering the same things that adults are getting for our young people, which has not been happening so much in the past. There are obviously there are differences in children, and there are age-related differences, and we will talk through a few of those today. So this is a long, slightly lengthy, boring definition of what a cardiomyopathy is, but we all know that it's a myocardial disorder, so it affects the heart muscle, and it's where the heart muscle is abnormal. And there's no cause that we know to identify that. And there's lots of different types of cardiomyopathies. So we now have these 5 types. So we're going to try and cover a little bit of all of these things, but we're mostly focusing on the hypertrophic cardiomyopathy because that's where we have the most evidence and it's also the most common, one of the most common in children. So you have hypertrophic cardiomyopathy where you have abnormal thickness of the heart muscle, but the heart pumps normally pretty well but can be stiff. Dilated, where the heart muscle is thinned and the heart itself is enlarged. This new non-dilated, where we see some scarring pattern. Sorry, that scar on the my thing's gone. On an MRI scan, and we know that they increase risk of arrhythmic events or abnormal rhythms. Arrhythmogenic right ventricular cardiomyopathy, where it's mostly affecting the right ventricle, again associated with abnormal rhythms, and then restrictive cardiomyopathy, which we see a bit more in children, where the heart is very, very stiff, but there's no thickness associated. So what do we see in adults and children? So in adults, by far the most common cardiomyopathy is hypertrophic cardiomyopathy, followed by dilated. So we see it's sort of the other way around in children. So the most common cardiomyopathy that we see presenting in young people is dilated, followed by hypertrophic, and then a smaller number of other things. In terms of how common it is, we know that in adults, actually, like hypertrophic cardiomyopathy is not that uncommon, 1 in 200 to 1 in 500 people. So if you're in a big stadium, there's bound to be at least a few other people there with the condition. In children, that's not so much the case. It is pretty rare. So we don't know exactly how common it is, but we think that it's sort of less than 1 in 100,000 people. So it's really actually pretty uncommon. But hypertrophic cardiomyopathy is the most common one that we see. So what's the cause of cardiomyopathy presenting in childhood? This is a graph showing up the ages that we saw when we looked at, this is a population of children with hypertrophic cardiomyopathy from the United Kingdom that we looked at a few years ago. And we see that actually it presents throughout the whole of childhood. We see a little spike in infancy, and then after that, then we see it really throughout the whole of childhood. And it used to be thought that we didn't see it, we saw it in infancy, and then we didn't really see it until adolescence and sort of early adulthood. But that's not the case. So we see it in the early childhood, we see it in, go backwards, and then mid-childhood, and then obviously also into adolescence. And again, we used to think that actually most of the disease was caused by all these really, really rare things. So metabolic disease, different sort of syndromes were associated with other problems in the body, so different sort of facial features, other things, neuromuscular disorders. And these are all individually very, very rare. And it used to be thought that most of the disease was caused by that. But actually, again, when we looked at it in the United Kingdom, what we found that the majority of the disease, and this is this blue and the pie chart up here, is idiopathic or familial, so some kind of genetic condition. And actually, even in the very, very youngest, if you look at that bar chart there, the blue there is, again, this idiopathic, so familial, non-syndromic causes. Again, even in the very, very youngest patients, the majority of disease was caused by this. So there's been a real shift over the last 5 years or so to say that actually it's not these really, really rare conditions that's causing the majority of disease, it's actually the same as adults. So this is data looking from a European registry, and it's showing the same thing, that actually, by far, the majority of disease is caused by familial disease. So that's hypertrophic cardiomyopathy on the left, but even the other conditions as well. In the very young under 10s in blue and the 10 to 18-year-olds in red, the majority, or at least a very high proportion of it, is familial. So these people have a family history, there's a genetic cause, whether or not we know sort of exactly what that is. So that brings us on to what the genetic cause is in the majority of people. And you may have seen something similar to this. So this is if you zoom into one muscle cell. These are the sarcomere proteins that we know that are involved in the muscle contraction. And there's lots of different proteins involved in it. And these are where our sort of the majority of our genetic causes are of at least hypertrophic, mostly dilated cardiomyopathy, a bit different for the arrhythmogenic. But the graph on the right-hand side shows that actually if we do genetic testing on children, even if they're very, very young, so if they're babies when we first do the genetic test, when they first present, or later in childhood, a large proportion of them have a mutation in these proteins, okay? So what genes are affected, which proteins are affected? You may recognize some of these, MYH7, MYBPC3. These are all the same as adults. So basically what we're saying is that actually childhood disease is more uncommon than adults. It definitely presents more in adulthood, but actually the underlying causes are the same in children for the majority of people. There are some people that have these rarer conditions, but the majority of people have the same underlying cause. So these protein mutations, you may have seen something like this before, are inherited in an autosomal dominant pattern. So that means that there's a 50% chance of passing it down to each of your children. So if you have a dad who's affected, which is that sort of D here, they can pass down one of their, remember back to school now, you can pass down one of your genes to your child and you'll get one from the mum, and it's just random which one happens. So overall, it's about 50%. So that doesn't mean that if you have 4 children, 2 of them will and 2 of them won't. It doesn't mean, but it just means that overall it's 50%. That's the way they're inherited. But even though they're inherited in this way, there's some strange things about the genetics of cardiomyopathies that you may sort of already be aware about. And one of them is that even though you're born with that genetic variant, as I said, it's mostly seen in adulthood. We don't see it right the way from birth. So there's this age-related incomplete penetrance. So this is a graph. This is data from Great Ormond Street Hospital and Barts Hospital of people that were referred for screening, where we knew exactly what the genetic cause was, and we followed them up to see when they developed the diagnosis and at what age. And what you see is that actually over time, you get an increasing number of people developing this diagnosis. This is male and female, so males had a higher incidence of it. And that's another strange thing, is even though it's inherited in this way, there's more males affected than females, which is not really explained. But over time, you get an increasing expression of this disease. So even though, and that's also important, why we need to keep following people up, or one-off sort of review and assessment isn't enough, because over time, you get expression of the disease. The other thing that's strange about the genetics of the condition is that even though you can have exactly the same variant in your family, the way that it expresses itself and the way that your heart can look can be very different in different members of the same family. And you may have experience of that in your own family. So this is just an example of a family who has a MYH7 variant here. And this person here is gene positive. And then we've screened the family. And if you screen a population of them, you sort of find that some of them will have hypertrophic cardiomyopathy. Some of them will not have anything at all. They have no hypertrophy, so no thickness. But even in those with no thickness, some of them will still have subtle signs. So their ECG, which looks at the electrical activity, may be abnormal. So we get this incomplete expression and very variable phenotype. So phenotype is just the way the heart looks. So it changes over time, and it's also variable in families. So if we go on to look at what we sort of do when we're looking after the children and young people, we sort of focus in 4 main areas. So we'll go through those one at a time. So screening, how we assess risk, how we treat symptoms, and then sort of specific lifestyle things that we like to think about. So if we talk about screening first of all, so lots of our thoughts about screening and the way we currently practice screening has changed in the last really 2 or 3 years. And that's because the previous thoughts about screening we've sort of shown now are not really correct. So we used to be sort of described that familial disease was uncommon during childhood, or actually that it just didn't happen. That when it did happen, the thickness developed in adolescence, so really when you're 14, 15, 16. And that even if it did develop, then actually disease complications were very rare in childhood, and they happened in adulthood. So because of that, the guidelines used to recommend us starting screening for children in those with a family history of hypertrophic cardiomyopathy at the age of about 10 or 12, depending on whether you were in Europe or in the United States. But there was some important work done. This is data from Great Ormond Street Hospital, and there was another study from Toronto that looked at the yield of screening. And this is for paediatric hypertrophic cardiomyopathy, but really very similar things are now being shown for all the other cardiomyopathies as well. So this was a large population of over 1,200 first-degree relatives that were screened. And what we found was that actually the diagnosis was made in 5% of the individuals that were referred for screening, and just under 9% of families. So not a huge number, but also not an insignificant number. If you think that that means that just under 1 in 10 families that you screen, you will identify someone with the disease during childhood. And when we looked at the ages at which they were diagnosed, again, it wasn't that they were all adolescents. There was a spread throughout the whole of childhood. And if you'd put the cutoffs of more than 10, more than 12, which the guidelines were recommending at that time, you'd have actually missed the diagnosis in a large number of those patients. And you could say, well, maybe it doesn't really matter, because if they'd had symptoms, then they would have come to you anyway. But I think we all know that that's not really true. You don't always, just because you get symptoms, get a diagnosis made in a timely way. And actually a third of those patients that had a diagnosis made had some sort of intervention. So either medication started, or they were assessed for risk and has an ICD put in, or referred for a new therapy. So making a diagnosis early matters for treatment, and also just so that people are aware and can make sure they put appropriate things in place. So now, and this is not just hypertrophic cardiomyopathy, we now have data from other cardiomyopathies. So this is data from a Dutch group looking at children with arrhythmogenic right ventricular cardiomyopathy, which is rarer in childhood. It's one of the rarer ones. But again, they saw a similar thing, that actually there was almost a 20% penetrance. So that means 20% of people during childhood, if they were known to carry the disease, had some features of the disease that developed during childhood. So if we're not looking for it, then we won't find it. But actually what it's sort of showing is that if we start looking, then we actually do find things. So there's now been a change in the guidelines to recommend starting screening at any age, basically. So if anyone has a diagnosis, then at that point, their first-degree relatives, whether they're children or adults, should be referred for screening. So one of the concerns about screening, particularly genetic screening, during childhood has always been that it could create lots more anxiety in the families and in the children, and that it takes away sort of their own autonomy for their healthcare. So we looked a little bit at the anxiety of our children that were undergoing screening at Great Ormond Street Hospital. This is some years ago now, 2016. But what we found was that the screening population, so those ones that were found to be gene positive but didn't have the disease, actually had very similar sort of quality of life anxiety scores to children that were completely unaffected and didn't have a family history. So it didn't seem to, if it's done in the correct way, the correct environment, with the correct support, we're not advocating just going out and having it done at Boots or anything, but done in the correct way, then actually the anxiety associated with it is sort of negligible and can be managed. Those with a diagnosis did have lower quality of life and anxiety scores, and I think that's sort of understandable and something we can work towards to try and sort of address. But actually that screening population doesn't seem to be such a significant problem as had been thought. And this has been shown in other studies subsequently that so it's the environment that's important, that there was a higher incidence of negative feelings, these orange feelings, in patients that had it done outside of a specialist service where they had access to psychology, access to a genetic counsellor, compared to those that had access to those sort of resources. And also that when they asked children and young people how they wanted to find out about their genetic testing status, what they all pretty much all said was that actually they wanted to find out at the same time as their parents. They didn't want their parents to find out first and then be told later, that they wanted to be part of that decision and find out. And obviously this will vary a little bit depending on the child's age, depending on the family setup, but overall it sort of gives us good sort of feelings that people generally, children and young people do want this, seem to want this and want it to be delivered in a good way. So this is the current screening sort of recommendations for children and adults with cardiomyopathies, and it puts a strong sort of emphasis on genetic testing. So when you have the diagnosis already made in somebody in your family, that person is offered genetic testing. So that's the proband is that first person, and then you might already know, I think there's some sessions later on about the exactly genetic testing results, but if you have genetic testing, you may get a disease variant. This is pathogenic, likely pathogenic identified. And if you're lucky enough to get that, because that's not for everybody, as some of you may know, then you can then have cascade genetic testing. So your first degree relatives could be offered genetic testing. And then if they're negative, then the big positive of genetic testing as part of screening is that then they can then be reassured and discharged from follow-up. So those are the people that we can sort of reassure and discharge, provided that we're certain that we have found the disease-causing variant. If then we test them and they are positive for that variant but have normal tests, then they enter long-term clinical follow-up. And we have then a group of patients that we have these variants of unknown significance, so we don't have enough evidence to suggest that they are definitely the cause. So for those people, we can't do genetic testing in the relatives apart from for a research sort of status, so they would also enter clinical screening. And then in the families where there's no genetic variant identified, which is a large proportion of patients, they also need to undergo sort of cascade clinical screening, so that would be with their normal sort of clinical tests. So we follow this sort of pathway now for children and the same way as adults. This is just saying that now we recommend that it's recommended in the guidelines that we incorporate genetic testing sort of routinely in our paediatric patients. So this is quite a nice diagram that comes out of the guidelines, and it says that the part of the reason why there sort of can be good outcomes in genetic testing in children is, as I said, doing it as part of a whole multidisciplinary team and thinking about the patient. So we know that not every child is the same, not every family is the same. It's not the same being 5 as it is being 15. So we need to change our management strategy for that. So there's lots of things that we think about. So we obviously think about the age, the family's experience with disease. That can sort of greatly change how people will think about it, understanding why they want testing or why they might want testing. Talking about having genetic counselling. So we have a genetic counsellor that's embedded within our service that all of our patients would see beforehand. And then it's really working together with the family to help them decide what do they want to do as a family at that point. And they can either have genetic testing at that point, and then we'll obviously follow the previous flowchart. But actually, if they don't want genetic testing, then that's fine as well. And it's not a once-only thing. It's not that you can only have genetic testing now, and then we don't offer it again. You can always come back, and we can revisit that later. And anyway, the clinical screening will just continue, and it will be exactly the same as if they had the variant. So these are some of the investigations that our patients will all undergo if they're having screening or if they're affected. So this is obviously an ECG. Many of you have had yourselves, but it's looking at the electrical activity of the heart. They'll all have an echo scan here, showing the heart. And then they will normally have at some point an MRI scan. So we normally reserve some of these tests for when they're a little bit older, so they can tolerate having it awake. So we normally wait until they're sort of at least 7 or 8, 9, maybe, depending on exactly what we're looking for. We use exercise tests. Again, we don't tend to do these until they're 7 or 8, 9, and they can actually do it. And then obviously the ambulatory ECGs that they wear when they go home. That's our sort of approach to screening in the young people. If we then move on to risk in young children, so if you were in Professor Elliott's, obviously one of the biggest roles of us looking after people with cardiomyopathies is to try and identify who might be at risk of having horrible events and help put treatments in to try and prevent those from happening. So it's exactly the same for our children and young people. So I think one thing to say is that obviously we have to recognise that actually predicting anything is very hard. It's particularly hard in children because we've already got a really rare condition, so the numbers are small, and actually the rare events, thankfully, are also uncommon. So actually predicting an uncommon event happening in uncommon disease is really, really tricky and really challenging. And I think there's an increasing sort of recognition amongst doctors and sort of families and things that actually we have to come somewhere in the middle. So as doctors, we often come looking at the evidence, what else is causing death, what are the burdens of having an ICD put in, because we know that putting ICDs in children is not exactly the same as putting them in adults. So they're much smaller, so they can't have all the devices that adults can have. And also, they're growing so much. If you imagine how much you're growing between the age of 4 and 15, it's huge. And actually, so the device has to be able to withstand that growth, and often it can't. So often there are other complications associated with it. So it's not exactly the same in terms of the burden of having these therapies. But we also know that obviously patients come with their own sort of cultural feelings, religious beliefs, and also social contexts. And in different healthcare systems across the world, there's also different pressures to either put devices in or not devices in. So somehow we have to come together to sort of find the right structure and strategy. So what the guidelines currently recommend is that this is basically done as a shared decision-making process so that we can bring some evidence and what the current sort of thinking might be, and that then the families will then bring their own feelings and thoughts about it, and that we work together as a team to try and work out what the best strategy is going forward. So we have, however, had a bit of a shift from how we assess risk in children and adults with inherited heart muscle diseases. So we previously used to look at particular risk factors that we thought were associated with, or we know are associated with risk, and then we would put you into two groups. You're either high risk, and we'd recommend an ICD, or you were low risk, and we'd say you don't need an ICD. We'll check again in a few years' time. There's now been a move towards a more individualised, personalised risk assessment, so where you get an individualised risk prediction, so, and then that allows us to give a personalised treatment decision. And this sort of has been around in the adults for 5 to 6, 7, 8 years, a little while now. But excitingly now, we for the first time also have similar things in children. So about 3 or 4 years ago, there was a big consortium put together led by Professor Caskey, who works at Great Ormond Street Hospital, and it's now sort of the largest research group of children with heart muscle disease, particularly hypertrophic cardiomyopathy in the world. And we created this score called HCM Risk Kids, which now allows us to give these individualized 5-year predictors and estimates of risk in children with hypertrophic cardiomyopathy. So obviously nothing is absolutely certain, but it means that now at least we can put some sort of figure on it to have discussions with families so that we can get some idea of what the risk might be. And the guidelines now recommend using these. So we don't use the adult ones because we looked at whether we could just use the adult ones, but as children are different, so we can't just do exactly the same as we do in adults. But we now have these paediatric specific risk models that we can use for risk prediction, and that's what we do in clinical practice. So we have good ones in hypertrophic cardiomyopathy. We don't really have the same yet in other cardiomyopathies in children, but we're sort of working towards trying to develop the same sort of resources and evidence base. So we then go on to thinking about symptoms, and I think so symptoms really with children is pretty, lots of it is quite similar to adults actually. They have the same symptoms. So the only thing that's different is that the very, very young tend obviously not to be able to report chest pain, things like that. So the very, very young might have like poor feeding, not gaining weight properly. That's just because feeding is like an exercise basically for the babies, sweating. But otherwise they have the same symptoms. So dizziness, chest pain, palpitations, syncope, fatigue. And the management strategies are very, very similar to adults, although we just have sort of slightly less evidence base for them. But what's really important with children is that they can have these other systems associated. So you might have, there's a higher number of people that might have, for example, kidney disease or respiratory disease or learning difficulties, things like that. So it's really important that we sort of work together with other people. So There's now guidelines and recommendations that it should, ideally care should be provided in a tertiary or a specialist centre, but if not, that there's good links to a paediatric specialist centre so that people can access the different specialties that they might need, as well as the cardiomyopathy specialists as well. I think that's probably similar for adults, but particularly important for children. And then finally, just to go on to lifestyle things. So, as I said, so I think we all know that childhood, adolescence, young people, there's lots and lots of things changing over that time. So it's really impossible to choose one thing, but we have tried to try and manage lots and lots of different problems and things that are happening. So exercise is a big one, obviously, for our children. And for the very, very young, it's sort of less of a problem because you can't really, children are just going to run around. They're not actually doing specific sort of training exercise. But as they're going into their teens, it's sort of providing advice about what they can and can't do, what careers may or may not be sort of suitable for them, and being part of those sort of decisions with them. Schooling, we often find we have to have quite close links with the schools, providing sort of letters, information for the staff. Sometimes our nurses go in and do training for the staff, just to try and sort of provide some information and evidence around what should be done. I put this person here with tattoos. Some of our patients want tattoos, but that's fine. Piercings, and then going into sort of pregnancy. So then this is sort of moving a little bit beyond our comfort zone, to be honest, in the paediatric hospital. But we have close links. We're trying to set up better links with the adult service so that that transition time is a bit smoother. And I think this is still an area that we're not so good at. So this is something that we still are trying to sort of work on, because at the moment there's still a bit of a jump between everything changing at the age of 18, when everything is already changing in your life, going to university, and then all of a sudden you have to go to a different place and you don't know anyone. So this is something we're still working on. And again, and alcohol, drugs, the effect of that going forward. But paediatric cardiomyopathy is really, I think one of the exciting things about it is that it's a really unique opportunity for intervention. So we're often seeing children either before they've developed disease or very, very early. And the advantage of that is that actually potentially we have the opportunity to either prevent the disease from progressing or change the course of the disease. So we're not quite there yet, but we're getting there. So in some diseases we have this now. So Pompey's disease is a metabolic disease associated with hypertrophic cardiomyopathy, and there is now an enzyme replacement. So this is not a large number of patients, but for these patients, they can have this enzyme replacement, and actually you see regression of the hypertrophy. They still have other problems related to it, but the heart is no longer the cause. They used to die very early from heart failure, and now they don't. Similarly, some children that have this particular syndrome called Noonan syndrome, there's now some increasing evidence that this particular therapy can, again, help reverse some of the hypertrophy and improve long-term prognosis. For the majority of the people, the myosin inhibitors that we've been hearing about and we're very excited about, we can't yet use these in children, but there are paediatric trials starting this year now. So the mavacamten trial started last year, and we're now starting to recruit at Great Ormond Street, and then the aficamten trial is starting now. So actually, it's starting with teenagers, but there's a hope that it's then going to extend beyond. So in the next few years, and there's no reason to think these drugs won't work in our young people just as well as they work in adults. So we're excited that we're going to have some new therapies that we can offer. And we also have gene trials starting. So Rocket is a gene trial for lamin, for Danon disease. And Tenaya is another gene therapy trial that's in very, very early phases for myosin C protein. And actually, our young people and our children will potentially be the best sort of recipients of this because they haven't yet developed the disease. It's not to minimize the effect of having gene therapy. These are, big, big treatments. But potentially in the future, in 5 years' time, we might be talking about very, very different things for our young people with cardiomyopathies. I think that's it. Yeah. So this is our team. This is our research team at Great Ormond Street Hospital, and this is our clinical team at Great Ormond Street Hospital. I'm happy to answer any questions you might have.
Very much, that was brilliant. Got a question. I don't know whether anyone else has got questions, but I've got one question here. So it's just to say that CRI, so cardiac risk in the young, they do screening for 18 to 35-year-olds for cardiomyopathies and channelopathies. Should this be a national programme? That's the first part of the question. Second part is, should they lower the age range?
Yeah, so good question. So yeah, so CRY do more population-based screening. So you don't have to have like a family history or anything like that. It's population-based screening. And they do screen some younger people as well. So they screen some of our teenagers. And we definitely get some referrals through that. And I think CRY is an excellent charity, and they're definitely doing really, really great work. I think that lowering the age group, yes, they definitely see some. I think they see we've definitely had teenagers come through, so I thought they see people definitely from 16 upwards. It might even be 14. I think the only tricky thing about screening, the way that sort of CRY do it is with younger people, is it's just how you sort of get to them. So we've looked a little bit at this about screening in schools and things like that. But there are problems because these diseases are rare. So we need to think about sort of what the sort of pickup is going to be of them, and then also putting them in, getting them into the system sort of quickly. So yeah, I think potentially going forward, but I think probably population-based screening, as opposed to some like conditions that, or as adults are more sort of for me like breast cancer, colon cancer, those conditions are more common in the population. So we're looking for rarer things. So probably sort of more directed screening. So making sure that everyone with a family history gets screened. Making sure those who have a family, not just of cardiomyopathies, but family history of sudden death get screened, because actually that doesn't always happen, is maybe a good way to sort of focus resources. But yeah, CRY do a really great job, and yeah, we see lots of patients through them.
So if a genetic link is found, so it says TTN DCM, would a 2-year-old be seen for echo ECG, or would it be later?
Yeah, so we would see them at the first time that it was diagnosed. So that doesn't necessarily mean, so it gets different genes. We are starting to get a bit more of appreciation that different genes can express themselves in different ways, and some of them are more associated with earlier onset and then later onset. So Titin, that's what you're referring to, is generally is reported to be associated with older onset disease, but actually we have families with young people, young children with Titin. So it's not, again, I think if we're not looking, then we're not going to find it. So yeah, the recommendations are that we should screen them at that first time that it's identified, with or without genetic testing, depending on what the family want, and then we just keep following them up. And then it depends, we may not see them very frequently. At the age of 2, we probably don't need to see them like every 6 months or anything. It might be that we see them once, and then we see them again in sort of 3 to 4 years, and then we see them more during adolescent time, because we tend to see things changing more around then when sex hormones growth is a bit more. But yeah, we'd start screening at the age of 2, yeah.
I'm not sure what the question says. Do you see AI, that's it, do you see AI helping with research and improving outcomes for the future? Sorry, it was the AI that I was...
Yeah, they're going, AI? Yes, definitely. So I think AI is like a huge resource. I think as of yet, it's not really translated into the big improvements in care that we were initially maybe thinking. So I think that we need to have a bit more of an idea about exactly how we train the data sets and things. But yes, definitely. And we're definitely, so part of the work that we're doing with this big international consortium now is trying to use AI some forms of AI to try and identify patterns that we can't do. The tricky thing with children is that we don't have very big numbers. And I don't know how much you know about AI, but generally you need big data sets for these things. And if you don't have big data sets, it all starts getting a little bit messy. But yes, definitely. And there's other people that are sort of working on like using AI for imaging and things, and whether some of that could be used to identify normals, abnormals, whether that could help with screening and reducing resources and things. So definitely yes, but not there yet.